think I'm going to go ahead and go. It looks like we're having a fairly good crowd joining in. So welcome everybody to our University of South Florida Department of Internal Medicine Grand Rounds. Here we are yet another Thursday and another great speaker joining us. Dr. Upshaw was mentioning some of her Florida ties, but she truly has a lot of New York in her. So Dr. Upshaw graduated from Columbia University to start her New York history here. It graduated from Columbia University in 2003 from her undergrad, and then went on to Cornell, where she graduated with her MD in 2008. From there, went to the other state, as is probably called in New York, to Massachusetts, where she graduated from Mass General in her general internal medicine, and remained in the other state of Massachusetts as she did her cardiovascular disease training at Tufts Medical Center, to include a year of advanced heart failure and transplant cardiology. Dr. Upshaw's CV is extremely impressive. I had the honor of reviewing it as well as her presentation, and she already has received several research awards at Tufts and has been accepted into the AAMC Early Career Women Faculty Leadership Development Seminar Program. So really it is an honor to have her speaking here. Her current title is as the Medical Director of the Cardio-Oncology Program at Tufts. And she is going to be speaking about something that is extremely relevant. There's no zebra here, but this is, I can tell you, a wonderful talk from doing the content review. And she's going to talk about advances in the treatment of heart failure. So we really appreciate you, Dr. Upshaw, taking the time to join us. And we are looking forward to your talk. Welcome.
Thank you so much for the kind invitation and the kind introduction. Can everybody see the slides look normal?
Looks great.
Center mode. Okay, fantastic. Excellent. Yeah, I'm going to talk about advances in the treatment of heart failure. I'm an advanced heart failure transplant cardiologist. I also run the cardio-oncology program, so we'll put in a little bit of details about how that kind of frames my thinking. But it's a great time to be a heart failure clinician. We have a lot of treatments and trying to figure out how to get them the right treatments to the right patients. Here are my disclosures. Pertinent to this is we were a site, and I was a site PI of the Victoria trial. I'll be talking about vericiguat. I'm going to talk about the universal definition and classification of heart failure, which is a great document, and I'll share some of the kind of updates from that. And then spend most of the time talking about advances in the treatment of heart failure with reduced ejection fraction, and then some exciting advances in the treatment of patients with heart failure with preserved ejection fraction. So this was a really great document, an effort from the Heart Failure Society of America, the Heart Failure Association of the ESC, and the Japanese Heart Failure Society, to try to come together, really kind of standardize some of the language about the definition of heart failure, since it is a syndrome and doesn't require, there isn't one piece of data, and as well as some classifications. And so, we would all recognize this, but it really, I think, is a nice definition for clinical care or research. Your symptoms and signs of heart failure. So the ones listed there on the right, typical ones that we'd all recognize: orthopnea, P&D, dyspnea exertion, and then signs of heart failure, and some structural or functional cardiac abnormality. And then one of the following: either elevated natriuretic peptide levels or objective evidence of pulmonary or systemic congestion. So either on a chest X-ray, pulmonary edema, or if you did a right heart catheterization, elevated filling pressures. So some either elevated BNP or some other evidence of heart failure. And these are these are coming up with thresholds for natriuretic peptides is difficult. These are the ones they chose, which are somewhat low. So for ambulatory, a BNP of greater than 35, or an NT-proBNP of greater than 125, and then higher for a hospitalized patient. And as we all know, there's a lot of things that can raise the natriuretic peptide levels. So thinking about that in the context of, is there another reason, like a pulmonary embolism or non-cardiovascular causes? So major ones would be, kidney disease, CKD can raise the natriuretic peptides, as well as older age. And then the major issue, especially with heart failure preserved ejection fraction, is we know that obesity can lower the natriuretic peptide level. So a patient can have heart failure with a normal natriuretic peptide level. So I think this definition really allows us to take all those things into consideration. And I think another really good advance for this document, about 20 years ago, the ACC AHA came up with stage A, B, C, D, which really was the first effort to really try to highlight that we can prevent a lot of heart failure. And so there is the stage A, which is about half of the adult population, patients with some sort of risk factor for development of heart failure, hypertension, diabetes, or patients I take care of that have received cancer therapy like an anthracycline or radiation, or have a family history. And so, labeling those stage A heart failure, although it wasn't used that much, still could be confusing because those patients obviously don't have heart failure, but recognizing that they are at risk for heart failure. So that's kind of the language I think that will be a little more useful. And then this pre-heart failure, with stage B, which I think is also a really important group where we can really intervene to prevent heart failure. So these are patients that have some detectable structural heart disease. So on an echo, they have LVH, or they have coronary disease and their EF is 45, but they never had signs or symptoms of heart failure. So they don't have the clinical syndrome of heart failure, but they have some structural abnormalities. Or kind of from the STOP-HF trial, they have an elevated natriuretic peptide without another cause, and we know you can actually prevent heart failure by, having them doing some further investigation and treatment. And then some updates to stage C heart failure. I think the big one, so this is, most of what we think of heart failure. This is patients that have ever had signs or symptoms of heart failure. So someone who has no symptoms now, but previously did, would stay in this stage C category. And that's, most of our work is with these patients. The big update here is there's this recognition that, fortunately, with medical therapy, patients can improve their EF to normal, and they can have no signs or symptoms of heart failure. And for a while, that was deemed recovery, but now we recognize that it's really heart failure in remission, because from the STOP-HF trial, we know that if we stop medications, a large percentage of those patients, more than 50%, will develop heart failure again. And then I spent a lot of time in this space with advanced heart failure. And kind of stage D heart failure, where patients really still have refractory heart failure after medical optimization. Another update from this document, small changes, and this continues to change, and I think gives everybody a headache how to classify. And I think this is a useful classification, and not a big change here, but heart failure, reduced ejection fraction, recognizing that heart failure is a spectrum. And EF is really important in so much as that's how the trials are done. So that's how we know, what medications we anticipate patients would benefit from. So heart failure with reduced ejection fraction being an EF of 40% or less. This range here, the mildly reduced, which used to be called mid-range, which kind of 41 to 49. This is an important group because I'll show you a little data. More and more we're realizing that a lot of patients in this category really do respond to the therapies that are been shown to be beneficial in the heart failure with reduced ejection fraction categorization. And then HFPEF, or heart failure with preserved EF, of 50% or more. And then this other category, heart failure with improved ejection fraction, which is also, fortunately with our medications now, we do have reverse remodeling, and a lot of patients do improve their EF, and so kind of putting them in this category, they don't have HFPEF, they have heart failure with improved ejection fraction, with some definitions there. This is a really nice document, kind of going through a decision pathway, an expert decision pathway for optimization of heart failure with reduced ejection fraction, using the guidelines. The updated heart failure guidelines from the ACC-AHA Heart Failure Society of America should be out in the next couple months. So there'll be some updates, but really, I'll show you the data here, but in those with stage C heart failure, so any signs or symptoms of heart failure in an EF of 40% or less, that everyone should be on an ARNI, so Sacubitril-Valsartan, or if they cannot be on an ARNI, ACE or ARB. and an evidence-based beta blocker, which carvedilol, bisoprolol, and metoprolol succinate, and diuretic as needed. And then patients with adequate renal function and no hyperkalemia should be on a aldosterone antagonist. Patients with reasonable renal function, now we're knowing that we're finding out that more and more that the SGLT2 inhibitors really can help chronic kidney disease. So, really GFR of 20 or higher should be on an SGLT2 inhibitor, the dapagliflozin or empagliflozin, and then, diuretics as needed. And then those that self-identify as Black would still, the data is older, but would still benefit probably from hydralazine, isodil if they have class 3 symptoms. And then this is a 2A recommendation currently, where if you have a heart rate of greater than 70 despite maximally tolerated beta blocker, and really probably 75 or higher in sinus rhythm, then patients may benefit from ibabradine. This is in the same document, just really, this is from the clinical trials and something that's, useful resource. So these were the starting doses in the clinical trials, and then these are the target doses. So trying to get patients as much as we can on the quadruple therapy at target doses. And so these are kind of guidelines here. So I like to, when I talk to my patients, I like to just reinforce, all the benefits and talk about the mortality benefit, improvements in functional capacity, health-related quality of life, reductions in hospitalizations. But I think really explaining the mortality benefit and the survival benefit of these medications can sometimes help adherence. So this is just kind of a summary from the clinical trials. So this is, from the solved in early days of ACE-ARB. The top two here, these are absolute risk reductions. The huge absolute risk reductions, 5% compared to placebo. This is from the solved data. And then this is from the Sacubitril-Valsartan from PARADIGM-HF compared to an ACE inhibitor. So really, really impressive over short durations, reductions in mortality. Same with the beta blockers, some of the highest relative risk reductions are 30% relative risk reductions and 4% absolute risk reductions at, a short period of time for carvedilol, metoprolol, succinate, and bisoprolol. And so this is old data now, 8 years, but, this is Sacubitril-Valsartan, which was a huge advance in basically the combination of valsartan and all the beneficial effects that we know in inhibiting the angiotensin pathway and reverse remodeling, and then also neprilysin inhibition and all of the potential benefits there. And this is PARADIGM-HF trial, showing really dramatic reductions in the composite endpoint from death from cardiovascular cause or for first hospitalization for worsening heart failure, significantly reduced clinically significant and statistically significant, and then also a reduction in death from cardiovascular causes here in heart failure with reduced ejection fraction in the PARADIGM-HF trial. Important questions from PARADIGM-HF. When it came out, there were no echoes in that study. It was really, a large clinical outcome trial. And so Jim Januzzi and others have done some really great work showing improvements in natriuretic peptides and reverse remodeling. So this is from the PROVE-HF trial, which was, single arm, just looking at the effects of Sacubitril-Valsartan on reverse remodeling. And not surprising given that we know that ARBs have this effect, but you see really dramatic, this the baseline that EF is 28%, median EF is 28%. LVs are very dilated. So this is indexed to body surface area, and 87 is very dilated. And then by 6 months, you see that reverse remodeling where the LV gets smaller and the EF increases to 34%. Left atrial size also decreases. And by 12 months, we see that there is really quite dramatic reverse remodeling where the LV is smaller to 74 and the EF's medians up to 38%. Another key question after PARADIGM-HF, which we all struggled with, was, that study, as we know, was done long run-in outpatients who were already on ACE-ARBs, who had, kind of chronic heart failure. And then there was a question, do you have to put everybody on an ARB, then switch them to Sacubitril-Valsartan, and is it safe to start it in the hospital? And so Pioneer-HF was a really important study showing us that it's safe to initiate Sacubitril-Valsartan in the hospital. Now, this was done, once patients were kind of optimized, they were off, IV medication, and they were stable, had a systolic blood pressure of greater than 100, but it was shown to be safe, importantly. And then, the primary endpoint was change in NT-proBNP. And there was also a signal for reductions in rehospitalization for heart failure. But the most important thing we know from Paradigm-HF that being on Sacubitril-Valsartan is beneficial for patients with heart failure with reduced ejection fraction. So this was really just showing that it can be done safely in the hospital. And we know that patients that leave with guideline-directed medical therapy are more likely to be on guideline-directed medical therapy at 6 months. It's harder. It's easier to initiate in the hospital, and is really beneficial to try to initiate guideline-directed medical therapy in the hospital, if at all possible. This is the mortality reduction with aldosterone antagonists from the eplerenone data from EPISIS-HF, and then this is from DAPA-HF, which showed a reduction in mortality in patients with heart failure, and I'll show you that as well. So, I think the story with, interrupt me if anyone can't hear me. I think hopefully we're good. The story with SGLT2 inhibitors, I think we've all been just shocked and amazed by, the question is, what can't they do? From EMPA-REG and CANVAS and DECLARE-TIMI, the striking signal in patients that high with cardiovascular risk factors or prevalent cardiovascular disease, and reductions in heart failure, and then improvements in renal function. And then the story from there has just been consistent benefit with these agents, and it's been kind of bedside back to bench to try to figure out why. And I think it's still being investigated, but there's many potential reasons why these agents are so helpful in patients with cardiovascular disease and renal disease, and shown here, improvements in energetics, the heart shifting from using glucose to using fatty acids and ketones, improvements in renal function, and really great work by Jeff Testani at Yale has shown that part of that story, I think, is that loop diuretics are probably harmful for patients. They increase renin, angiotensin II signaling and cause neurohormonal activation, and that probably it seems like the SGLT2 inhibitors can lead to volume loss without that adverse neurohormonal activation, and improvements in arterial stiffness, and so I think that these are we're still discovering all the mechanisms by which these are beneficial, but they definitely are. So the DAPA-HF trial we have was the first to show benefit, and it showed that dapagliflozin reduced. So this was a study in patients with heart failure with reduced ejection fraction, 40% or less, who were on guideline-directed medical therapy. Although I'll show you, this study started kind of before Sacubitril-Valsartan was as widely used as it is now. But the primary outcome was CV death or first hospital or hospitalization for heart failure, and you can see here in panel A that it was reduced by 26%, driven by both the components of the composite, so reductions in hospitalization for heart failure. And just to point out here just how quickly these curves separate, which has been also a dramatic story and kind of shown consistently through all of the SGLT2 inhibitor trials that have looked at heart failure outcomes, really quick benefit, early benefit. And DAPA-HF also had a statistically significant reduction in death from cardiovascular cause, and death from any cause. Importantly, this trial showed, this is also true with Sacubitril-Valsartan, class 2 patients, where sometimes I think there's some therapeutic hesitancy where patients are kind of doing okay. So class 2, like sometimes there's kind of like, you're doing all right, I don't need to rock the boat, but really showed benefit. This is also true for Sacubitril-Valsartan. And then importantly, this trial enrolled patients with HFrEF regardless of diabetes, and half had diabetes and half did not have diabetes. And the benefit was, consistent regardless of diabetes status. So SGLT2 inhibitors help heart failure regardless of diabetes status. And, unfortunately, only about 11% of DAPA-HF subjects were on Sacubitril-Valsartan. Most were on ACE or ARB. So it's not perfect, but they did see that there was a consistent benefit regardless of if patients were on Sacubitril-Valsartan or not. So I think that these 4 therapies, ARNIs, beta blockers, mineralocorticoid receptor antagonists, and SGLT2 inhibitors are really additive, and the benefit is there on top of other therapies. So really consistent findings in EMPEROR Reduced, which was in Dapagliflozin. Both trials, DAPA-HF and Dapagliflozin, the dosing is 10 milligrams of the SGLT2 inhibitor daily, no up titration, so pretty easy trial, pretty easy therapy to add on. And they saw that there was also really early separation of the curves. By about a month, you see some benefit. And then they also looked in this trial at first and recurrent hospitalizations for heart failure as a secondary endpoint, and it also showed really clinically meaningful improvements in total hospitalizations for heart failure within Dapagliflozin. Similar story where there's benefit regardless of diabetes, and about half the patients had diabetes and half didn't. And there was about 20% baseline use of ARNIs, and also consistent benefit in kind of the 20% that was on Sacubitril-Valsartan at baseline. So now at this point, we have quadruple therapy for heart failure with reduced ejection fraction with Sacubitril-Valsartan or an ACE or an ARB if unable to tolerate ARNI. And I will say the lowest dose of Sacubitril-Valsartan, 24, 26 twice a day. There's some patients that lowers the blood pressure too much and they can't tolerate it. Carvedilol, metoprolol, succinate, or bisoprolol, aldosterone antagonist, and currently Dapagliflozin and Dapagliflozin have FDA indications for heart failure with reduced ejection fraction regardless of diabetes status. And this is a network meta-analysis just trying to demonstrate the benefit. Obviously all these trials had one additional therapy compared to placebo on top of some baseline evidence-based standard therapy, and this just uses network meta-analysis tools or methods to kind of estimate what would if you had a placebo trial where you had Sacubitril-Valsartan, beta blocker, and aldosterone antagonist, you would have about a 63% reduction in all-cause mortality. And this analysis was done before we have SGLT2 inhibitors. So, really, we're in a good place if patients that we can get on the 4 kind of foundational therapies of Sacubitril-Valsartan, beta blocker, aldosterone antagonist, and SGLT2 inhibitor, we really can improve their outcomes. And this is a little bit older data. This is the CHAMP-HF registry, which was a large registry of about 60 sites, cardiology, primary care sites throughout the country, and about 4,000 patients, and kind of just looking in a longitudinal way in a registry fashion at heart failure therapy and heart failure care. And so this is old now, but I think we're still kind of a similar story where we're having a hard time getting all the patients that we really should onto to guideline-directed medical therapy. And so this is, ACE, ARB, or ARNI, and they had enough data to kind of say there were about 25% of patients here in red, did not have a contraindication, but were not on one of those ACE, ARB, or ARNI, and about a third were not on a beta blocker without a clear contraindication, and about 65%. So I think this is probably better now. This registry ended in 2017, but I think we're still a little ways from where we need to be. And then, I think that there's some practice variation and debate among heart failure cardiologists is, how to start these 4 therapies. Do you try to get everyone on them right at once? I think in the hospital we usually do. So someone admitted, especially if their EF is quite low, and they have the blood pressure room and the renal function, you're trying to get them on all 4 therapies. I think as an outpatient, we tend to do one at a time. But this is an editorial that really kind of trying to make the case that getting patients on all 4 at the same time or as quickly as possible. Because they look at kind of, as I showed, there was this early separation of the curves in a lot of these studies where if you don't get patients on them quickly, some patients will die or be readmitted, and you kind of lost an opportunity to get patients on this foundational medical therapy. So I think more research, kind of implementation research, and kind of showing how to do this safely. I think the other good point from this article is that, in some ways, starting all 4 at once may increase tolerance of the medications, because we know, for example, Sacubitril-Valsartan versus enalapril, in the PARAGON trial, there was less hyperkalemia. And we know that SGLT2 inhibitors are associated with improvements in renal function. So I think there's a case that maybe being on an ARNI, being on an SGLT2 inhibitor will kind of increase the tolerance to aldosterone antagonists, for example. This is from that consensus document that I showed earlier from the ACC, kind of going through considerations to improve adherence. And I just highlighted the one that I think we're all trying to do more is really to try to start the guideline-directed medical therapy and optimize it while patients are in the hospital before they're discharged. And then I think also kind of talking through with patients to really make sure they understand the benefits and kind of tailoring it to what's most important to the patient. These medications all have data that they improve health-related quality of life and reduce hospitalizations. And I showed you that also improve survival. So I think kind of trying to make sure that we convey that. And then these are kind of some reasons for non-adherence that we all know and help patients through. And I think really, obviously the elephant in the room is the cost and the out-of-pocket costs. And some patients just, no matter what we do and trying to look for patient assistance programs that they don't qualify, or we're just unable to get the patients the medications that they need. And this is just one analysis looking just at Sacubitril-Valsartan. And this is for a patient that had Medicare and Part D and what their out-of-pocket cost would be per year. And, this is 1,626 and just not affordable for some patients, some older patients that have limited income. So that's kind of whirlwind review of, really the evidence for what we are calling quadruple therapy or foundational medical therapy. And then kind of just talking about other things that we think about when we are seeing patients with heart failure with reduced ejection fraction. This is the data for ivabradine that I alluded to earlier. So, ivabradine is a IK funny channel, so potassium channel that works directly in the sinus node to reduce heart rate. So only would work in patients in sinus rhythm, and showed that in the SHIFT trial that in patients who were on maximally tolerated beta blocker and still had a heart rate of greater than 70, that there could be improvements in cardiovascular death or hospital admission for worsening heart failure, driven more by admission for worsening heart failure. So it's a therapy that's there, but really, focusing first on the 4 other medications that really consistently seem to improve survival. Another thing that we often, make sure that we look for is screening for iron deficiency. Iron deficiency is very common in patients with heart failure. About 50% of patients with heart failure are iron deficient, and supplementing with oral iron. So the Iron Out trial was a Heart Failure Network sponsored trial that showed that oral iron was not effective in improving iron stores, so basically not absorbed, and also didn't improve functional status. But IV iron does seem to work. So, most of the trials use a consistent definition of iron deficiency, so either a ferritin of less than 100 or a ferritin between 100 and 300 and iron stat of less than 20% for inclusion. And the data is a little bit stronger for heart failure with reduced ejection fraction. And so shown here is one trial. There's now been multiple showing that if you take patients with heart failure who are iron deficient and replete their iron. Here, this is ferric carboxymaltose, but there's been several different formulations that you can improve 6-minute walk test distance. You can reduce fatigue and improve health-related quality of life or health status with this as assessed by a common tool, the Kansas City Cardiomyopathy Questionnaire. And then not to forget cardiac rehab, insurance covers based off of this is the HF Action trial, which looked at supervised kind of with cardiac rehab in patients with heart failure with reduced ejection fraction, showing, unfortunately, it was not statistically significant without adjustment, but there were some differences in the baseline characteristics. So, the adjusted hazard ratio was significant, but it improved, so this was all-cause mortality or all-cause hospitalization. And then importantly, an improvement in 6-minute walk test distance, CPET, and kind of improvement in functional capacity. So it can be a great resource and basically, requiring that patients have a diagnosis of heart failure with reduced ejection fraction and be stabilized after an admission and kind of be on stable medications for at least 30 days. And not a lot of updates kind of in cardiac resynchronization therapy or biventricular pacing and ICDs. We know now pretty clearly, so definitely patients with ischemic cardiomyopathy benefit from ICDs, probably patients with non-ischemic, although there's a little bit of debate in trying to kind of figure out which population needs it the most, but definitely meet criteria. So having a shared decision-making discussion about ICD, and then, biventricular pacing or cardiac resynchronization therapy in patients who have an EF of less than 35% and a left bundle branch block of a QRS of greater than 150, or is the strongest indication of benefit, although patients with QRS, a non-left bundle branch block or pattern or a QRS of 130 to 150 may benefit, and especially women. Women have a more narrow QRS complex at baseline, and so there's pretty consistent evidence that women with a left bundle branch block pattern with a QRS, definitely like 140, or kind of between 130 and 150, are more likely to benefit than men. And so I think that that's a population where I would consider it. And then, the COAPT trial, everyone's seen this, just really dramatic improvement. So this trial was done, with careful attention to maximizing guideline-directed medical therapy, function in patients with functional mitral regurgitation. Many patients with functional mitral regurgitation, the mitral regurgitation will improve pretty dramatically with medical therapy. As I showed you kind of from the PROVE-HF data, you get a lot of reverse remodeling with medical therapy. So a lot of times MR will get better, but in patients who have severe MR despite maximally tolerated guideline-directed medical therapy, that the edge-to-edge mitral valve repair using the mitral clip in this study did reduce hospitalizations for heart failure and death. So in the right patient population, I think patient selection here, there's a lot of, it's careful art. There's clear patients that definitely will benefit. And then I think it comes up a question, especially when the EF is lower and the LV is more dilated, less likely to benefit. And so I think that there can become, discussion and definitely shared decision-making about the likelihood of benefit. And then, there is a recent medication that was recently FDA approved is vericiguat. And so this medication targets it's a soluble guanylate cyclase activator. So in patients with heart failure, there is reduced sensitivity of eNOS and reduced NO, and thus reductions in cyclic GMP, which can lead to vascular dysfunction and myocardial dysfunction. And so vericiguat is one of the few medications that's an activator. It's not an inhibitor, and it activates soluble guanylate cyclase and increases cyclic GMP in blood vessels and the myocardium. And then there was the Victoria trial, which was a phase 3 trial. It had a little bit of a different inclusion strategy than some of the other HFFEF trials that I showed you. It took patients who had a recent hospitalization or recent IV diuretic requirements, and kind of more of a worsening heart failure population, and randomized to vericiguat versus placebo. And you can see here that there is a benefit, although it's not a very large benefit, and the hazard ratio is 0.9, and there's benefit, but not clear really how dramatic it is. And then, importantly, I think for this population, this heart failure with reduced ejection fraction population, since we have, so many therapies that reduce mortality, it was mostly driven by reductions in heart failure hospitalization, no clear signal for reductions in death. So, at this point, we await the ACC updated heart failure guidelines, but the ESC guidelines were updated last year and recommended vericiguat as a 2B recommendation. So you could consider it in patients who have heart failure with reduced ejection fraction. I'll say I haven't used it much. I think that the populations that it's a fairly safe medication. It does lower the blood pressure a little bit, but it's not renally cleared and can be used in patients with renal dysfunction. So the patients I'm seeing it being used in are, and that I've used it in, those that can't tolerate some medications like ACE ARBs or aldosterone antagonists. So there is another trial ongoing that's in more of a stable chronic heart failure population. So I think maybe we'll get some more information on whether vericiguat will play a larger role in management of patients with heart failure. So exciting updates in the management of patients with heart failure with preserved ejection fraction. In August at ESC, this Emperor Preserve trial was presented, showing that in patients with an EF of 40% or greater who had symptomatic heart failure and had at least a mild elevation in natriuretic peptides. So with heart failure with preserved ejection fraction, that the SGLT2 inhibitor dapagliflozin compared to placebo was associated with a reduction in the primary outcome, which was a composite of cardiovascular death or heart failure hospitalization. They also did an analysis, like I showed you, for Emperor Reduced and Emperor Preserved, analysis of total heart failure hospitalization, so first and recurrent, showing an improvement with dapagliflozin compared to placebo with a hazard ratio of 0.73. There was no significant reduction in cardiovascular death. Numerically a little bit lower, but not statistically significant. So really at this point, improvements in heart failure hospitalization, and then importantly, improvements in, I guess one point, improvements in, Kansas City Cardiomyopathy Questionnaire scores. So, which is a validated health-related quality of life assessment tool for patients with heart failure, where higher scores are associated with better health status, showing some improvement in the KCCQ. They saw, similar to in the heart failure reduced ejection fraction studies, we see the benefit appears to be the same regardless of diabetes status. Again, about half and half with diabetes at baseline. I'll show you this too. So it seems that, there is benefit, and these are subgroup analysis, and so it's not powered, but it seems like the greatest benefit is probably those who have an EF between 40 to 50 or 50 to 60. Although, it's still trending towards benefit even in those with 60% or higher EF at baseline. This was a more detailed analysis from the same study of Emperor Preserved, showing these are just different thresholds of the Kansas City Cardiomyopathy Questionnaire score. So this is clinical status, total symptom score, and overall status. So just kind of different health-related quality of life metrics. And it's important because, patients with heart failure with preserved ejection fraction, tend to have lower risk of cardiovascular mortality compared to HFrEF patients, and tend to actually more commonly die of non-cardiovascular causes, but have a lot of symptoms and a lot of impact on their quality of life from their dyspnea and other heart failure symptoms. So, improvement in symptoms may be a more important outcome for patients with HFpEF, as long as the therapy is safe. And then, updates over the last couple of years in Sacubitril-Valsartan for heart failure with preserved ejection fraction. So this was the PARAGON study, which looked at Sacubitril-Valsartan compared to Valsartan alone in patients with HFpEF, also EF of 45% or higher. And there was a trend towards benefit, but no statistical benefit compared to Valsartan in the composite of total hospitalization for heart failure and death from cardiovascular cause. So it was a neutral trial, although, trended in the direction of potentially a favorable result. No difference in death from cardiovascular cause. So here you can see the point I was trying to make earlier, that really compared to HFrEF trials, there's pretty low CV death risk over 4 years, and really focusing on improvements in symptoms and improvement in patient centered outcomes is really important in this population. So this was the PARAGON-HF trial, so a negative trial, a neutral trial, and again, just kind of showing here that there was numerically fewer heart failure hospitalizations, no real significant difference in cardiovascular death, and really not a clear signal for the Kansas City Cardiomyopathy Questionnaire improvement. So unlike SGLT2 inhibitors, which seems like there is association with improvements in KCCQ and other health-related quality of life, not as clear a story for Sacubitril-Valsartan. But there was this treatment by subgroup interaction where it seemed like in the PARAGON-HF trial, there seemed to be more benefit in women, and which was about half the population, and also more benefit when the EF was on the lower side. So again, they enrolled patients with 45% or higher, and so it was actually the label for Sacubitril-Valsartan was actually updated to change the language, which had previously been indicated for a HFrEF population, to now indicated to reduce the risk of CV death and heart failure hospitalization in adult patients with chronic heart failure, with benefits more clearly evident in patients with an EF below normal, kind of based on this and other analysis from the trial. And one more, they this really good paper, they pooled Paradigm-HF and Paragon-HF populations. They pooled the two studies, and then they looked kind of on the x-axis is baseline ejection fraction, and then on the y-axis is the relative risk reduction of Sacubitril-Valsartan compared with enalapril, which in Paradigm-HF, or Valsartan in Paragon-HF. And 2 points that as the EF gets higher, there's less benefit, but it seems to vary by gender. So women are in red and men are in blue. And the point where you lose the benefit of Sacubitril-Valsartan compared with ACE or ARB is at a much higher EF for women compared to men. And there's a lot of, we don't really know why this is, but it may be in part because women have a higher EF to start with. And so a normal EF is actually higher for women than men. So you may just be catching some contractile dysfunction at a higher EF for women than men. But it does seem like definitely kind of in this 40 to 50 range, and then for women, maybe potentially even higher, that there could be benefit for Sacubitril-Valsartan. Again, this is mostly driven by reductions in heart failure hospitalization. Kind of disappointing was the Parallax study, which was recently published. It looked at kind of important endpoints of submaximal exercise capacity with the 6-minute walk test distance. So co-primary endpoints were 6-minute walk test distance and NT-proBNP in a population with heart failure with preserved ejection fraction, randomized to Sacubitril-Valsartan or background medic, which was mostly an ACE or an ARB. So there was a benefit in NT-proBNP, but no benefit at all in 6-minute walk test distance. And this study also confirmed what we saw in PARAGON-HF, where there's really not a clear benefit in health-related quality of life as assessed by the Kansas City Cardiomyopathy Questionnaire. So I think it's still a little bit of uncertainty, and we need more research to really understand exactly where the role is. But some role, I think, especially in those with this heart failure with mid-range EF or mildly reduced EF. TOPCAT, we saw that spironolactone, that it did not meet its primary endpoint, but when there was a subgroup analyses by enrolling region, that there was clear differences where the patients that were enrolled in Russia and Georgia did not have heart failure and did not seem to benefit from spironolactone, where those enrolled in the Americas did. And so this is still a 2A recommendation in the last iteration of the ACC guidelines. But, I think in some patients with HFPEF, especially those that have kind of a 40 to 50% range, or who are on high loop diuretic requirements and requiring potassium supplements, I think that aldosterone antagonists can be useful. And then, really now we have tafamidis for the treatment of TTR amyloid. And so really focus on screening patients with HFpEF for TTR, for amyloid, for AL and TTR amyloid with blood tests and a PYP scan, and thinking about tafamidis. And this is the results of the tafamidis versus placebo study in patients with TTR amyloid, showing improvements in all-cause mortality with a hierarchical endpoint, and then really great improvements in functional capacity and symptoms. And then lastly, just I spend a lot of my time taking care of patients with advanced heart failure. We have a large transplant LVAD center, and then just kind of, and as I know you do too, at USF. So this was a really great scientific statement, trying to kind of talk through some of the issues of when to consider a patient as having stage D or advanced heart failure, and kind of when to think about evaluation for heart transplant, LVAD, or palliative care. And these are things that we all see, definitely inotrope dependent, multiple hospitalizations, having to down titrate or stop guideline directed medical therapy, are all, clues that we may be heading there. And, this is definitely can be tricky for some patients. You definitely don't want to list someone for transplant too early. They're much more likely to have better long-term survival on medical therapy, but you also don't want to wait too late. And patients who, as they transition to advanced heart failure, have develop cardiac cachexia and frailty and multi-organ failure. So just kind of thinking about that, and just trying to consider for a patient whether they may be moving towards needing to think about LVAD or transplant. So with that, I will stop and see if there's any questions, but basically kind of big takeaways for, we're in a great place for the management of heart failure. We have a lot of great therapies, including ARNIs, beta blockers, aldosterone antagonists, and SGLT2 inhibitors for patients with heart failure with reduced ejection fraction. And there's another trial called the DELIVER trial for HFPEF with Dapagliflozin. And so we'll see if that's consistent with emperor reduced, and then kind of considering other causes of cardiomyopathy. And it is Heart Failure Awareness Week, which is probably the reason to have this topic this week. And I really appreciate the opportunity to share a little bit of the updates in heart failure management. Thank you.
Thank you, Dr. Upshaw, for that excellent presentation. We'll open it up to some questions. Looks like everyone is fully satisfied. Outstanding. Well, we really welcome again to USF virtually. We enjoyed the presentation greatly, and thank you for a reminder that it is Heart Failure Awareness Week, and this talk was even more perfect for that. So we appreciate you being here with us today, and look forward to seeing you live in person sometime in the near future.
Fantastic. Well, thanks again.
Everybody have a great day. Thank you.